Good evening, everyone. So, today, once again, we are back with ISA's another webinar series. So, today is a very important day in which we are going to start or launch a very important webinar series called Clinical Excellence Masterclass. In this Clinical Excellence Masterclass, today we will be having the first episode, and this Clinical Excellence Masterclass will be conducted every fourth Tuesday of the month. So, the idea behind this clinical excellence masterclass is that we will be having case-based discussions about different type of allergic manifestations. So today we have with us Dr. Puneet from Bangalore, and Dr. Puneet is a pediatrician and allergist, and he is currently working at Bhagwan Mahavir Jain Hospital at Olavu Clinic, Girinagar, Bangalore. Welcome, Dr. Puneet.
Good
So,
evening,
Dr.
sir. Thank
Good
you.
evening. Dr. Puneet will be discussing a case today on wheat dependent exercise induced anaphylaxis. Many of you might have heard this term, might have thought that this is probably a rare entity, or probably in India the cases never happen. But we will be, while we will be discussing this case, then you will actually come to know that there are so many cases, there are so many patients which are around us and which we are unable to suspect this particular entity. So, this particular entity requires a high index of suspicion. And without much delay, I would like to request Dr. Puneet to start his presentation. Dr. Puneet, please.
Sure, sir. Thank you. So today's case presentation is on wheat-dependent exercise-induced anaphylaxis. So the case details, we had our patient, Mr. Santosh Kumar, about 38-year-old male. He works as mechanical maintenance department at Jindal Steel Plant in Bellary, Karnataka. And he stays in the Jindal Steel Plant quarters in Toraganallu in Bellary. And he was admitted in our hospital at Bhagwan Mahavir Jain Hospital, Girinagar on 27/11/2025. So his chief complaints were he had a sudden onset of rashes all over the body associated with itching, shortness of breath, pain abdomen, and dizziness since about 10:30 a.m. that day morning, and it was not relieved by tablet bilastin which he already had with him. History of presenting illness. Patient presented with above complaints to our emergency room, which was followed by an overnight travel. He had traveled from Ballari to Bangalore the previous night. He had breakfast after reaching Bengaluru and had walked a while prior to this episode to catch the bus. So he said to have been walked about 1.5 to 2 kilometers from the main bus stand to the hotel and from the restaurant to the city bus stand. Past history. He is a known case of chronic spontaneous urticaria since the age of 20 years. That is, since the last 18 years, he's been having this condition, which increased in symptoms since the last 2 to 3 years. He had two episodes of anaphylaxis in the past, and the first episode goes like this. In September 2022, he was attending a family's wedding reception where he had to work a lot. Like he had been woke up early in the morning and after the wedding reception was over to drop all his family members from the chowdhury. He was driving his car at around 2:30 a.m. in the midnight. While driving itself, he noticed sudden onset of rashes and it seems he fell unconscious. Noticing this, the person who was next to his seat made him lie down and water was given and symptoms settled. So this was his first episode in September 2022. Second episode was on 29/8/2025. He had breakfast as usual in the morning. He went for cycling and there was a sudden onset of rashes all over the body with fall in BP. He said he fell unconscious and was told to have low BP once he reached hospital. So he was taken to the hospital immediately by the bystanders there. Some IV injections were given along with some IV fluids and later discharged the same day once he was conscious. So for further evaluation, he went to a hospital. He traveled all the way from Ballari to a hospital in Bangalore, where SPT was done and was found to be normal. And this SPT which was done was like within 1 week of the second episode of anaphylaxis. He was referred to dermatology department because SPT was normal, where in dermatology department he was advised to take tab bilastin for a very long time, and it was particularly given for his skin rashes. He was also told few other tests, but he did not follow up there. He's not a known case of diabetes, hypertension, or thyroid disorders. Family history, no history of similar complaints in the family. Personal history, he has an active lifestyle. He is into regular jogging, walking, cycling, and hiking. At least 2 times in a year, he will be hiking the base hills of the Himalayas, is what he told. He is a non smoker but a social drinker. He hails from a upper middle class society. Coming to the clinical examination,
Dr.
yes, sir.
Dr. Puneet, let us pause here and let's go back to the history. So, as per the history, what I can gather from this history that this is like around 38-year-old gentleman who was having some previous history of chronic urticaria and the cause is unidentified by doing certain tests. We really don't know that what type of extracts they were used, which particular allergens were tested at that particular time, who did the test at that particular time, whether the test was done at least 4 to 6 weeks after an episode of anaphylaxis or was within that time period. So it is difficult to predict that what was the reliability of that particular skin prick test which was done at that particular time. But yes, definitely, whatsoever history you are telling, it seems that this particular gentleman is having some sort of arterial features which are for, you can say, like now decades, which are there. And then now, 3 episodes of anaphylaxis, even the first complaint which you just mentioned that the patient presented to you in your emergency and got admitted, at that time also it seems to be anaphylaxis because there are two systems or more than two systems are involved and acute presentation which is there. And then the previous two histories are also very characteristic that of anaphylaxis. So it is like 3 episodes of anaphylaxis which are happening now more frequently. Earlier, an history of urticaria which is there. There is no significant history of family history or anything. The other important factors which you mentioned that this particular person takes alcohol sometimes, but you also mentioned that this particular person is not having any sort of diabetes or hypertension or thyroid disorders. So, would you like to explain, as we are discussing here, wheat dependent exercise induced anaphylaxis or food dependent exercise induced anaphylaxis? So, I just want to know that with this particular entity, how it is different from food allergy. Like a person who is presenting to us with typical food allergy versus food dependent exercise induced anaphylaxis. Are they too similar? Are they different or are they overlapping? What do you think?
Sir, slightly they are different because the pathophysiology in food-dependent exercise-induced anaphylaxis is slightly different from the normal food allergy what we see. In the normal food allergy, there are few other risk factors like severe atopic dermatitis, or there could be family history of atopy or any allergies, and there could have been change in geographical location. So these things play a bit more role, but in food dependent exercise induced anaphylaxis, intake of food is correlating with the cofactors, mainly exercise or few other cofactors sometimes. It could be stress in his first episode, it could be exercise in his second episode, again, it could be exercise in his third episode, along with sleep disturbance. So, there should be a cofactor to define it as food dependent exercise induced anaphylaxis associated with food, and it should be between at least 4 hours. The exercise and the cofactor and the intake of food should be in between 4 hours, sir. But whereas in food allergy, it can be just immediately after the intake of food, there could have been allergy or anaphylaxis.
So I think it is a beautiful explanation which you have given. So let us discuss this a little bit more also. More in the sense, like for an example, food allergy, we understand that food allergy has several mechanisms. The best understood mechanism is IgE mediated, in which what we can understand that whenever the food is coming and the person is exposed to a particular food, then at that time, in a previously sensitized person, now the IgE is produced, and this IgE, ultimately the food particles are getting attached to that and mast cells are degranulating and the person is reacting to it. So this is something like a IgE mediated food allergy which we understand commonly. But there are other non-IgE mediated mechanisms of food allergy which are there, but they are little poorly understood.
Yes, sir.
Whereas in case of food dependent exercise induced anaphylaxis, it seems that food alone is not sufficient enough as a trigger. but probably it requires another cofactor so that the food allergies can manifest. So if you ask me, I will keep food dependent exercise induced anaphylaxis under the umbrella term of food allergy only or IgE mediated food allergy only. Reason behind, because it is like a spectrum. In a spectrum, a particular food item, a particular food item, it by itself may be sufficient enough to produce the complete reaction. That complete reaction could be your food induced allergy or food induced anaphylaxis, or the food itself is not sufficient enough, it requires a cofactor along with it, right? Once this cofactor comes, this could be exercise, this could be certain drugs. I'm sure we'll be discussing about that. These could be certain drugs, these could be certain other cofactors like extremes of temperature and stress. Then at that particular time, the absorption of this allergenic food increases. When the absorption of this allergenic food increases, so ultimately the previously sensitized person, in the presence of this allergenic food particles or allergenic food peptides, ultimately react to this particular food, which he was not reacting previously because the absorption was lesser. So you can consider it like that, that it is also a type of IG mediated food allergy, but it is the food itself is not a complete trigger, it is like a half trigger, and it requires another cofactor or probably a combination of cofactors to, you can say, like manifest. The other important thing here is, like for example, food dependent exercise induced anaphylaxis, sometimes the complete food or the whole food allergen might not be the culprit. It might be a particular component of that particular food which might be culprit. And as you mentioned that the skin prick test was negative, so it is possible that that particular component might be poorly represented in the whole skin prick test extract, and that might be the reason of getting a negative skin prick test when you are testing with a whole extract. But if you are testing with the components, then at that particular time you might be able to, you can say, like get a positive reaction. So yes, but beautifully explained that this is something like type of a food allergy. The other question is that, uh, like, how it is related with alcohol. Like, do you really think that alcohol is a very strong factor, or how it is related with alcohol intake?
Sir, there are various mechanisms why alcohol can be a very good important cofactor in food dependent disease induced anaphylaxis. One thing is intake of alcohol increases the permeability of the gastrointestinal tract. Second thing is the alcohol itself can damage the gastrointestinal tract, and that can lead to increased deposition of these proteins into the bloodstream. Then alcohol itself can cause gastritis, where in recent reports it has been told as gastritis as an independent risk factor for food dependent excess induced anaphylaxis, sir.
Absolutely perfect. Absolutely perfect, Dr. Puneet. What a few more things. Many times, what happens that whenever a person who is going to, like, say, parties, and the parties, whenever in the night party especially, there is some alcohol which is served. So the person who is, you can say, like taking some alcohol, and invariably during the time of alcohol intake, there is some sort of song or music or dance which is happening. So that acts like a exercise. So alcohol itself might not be sufficient enough to, you can say, like act as a complete cofactor, but it might be, you can say, like one of the cofactor added up with an additional exercise in the form of a dance, added up with an additional exercise in the form of some snacks which are also going on. That could be probably the wheat based snacks or the seafood based snacks or some other snacks which are also going on. So, and if a person has already taken certain drugs, these drugs could be probably non-steroidal anti-inflammatory drugs or something like that, because of some reason or variable reason. So ultimately, these factors combined together will produce the result. Whenever I see my patients, then I usually explain to them that it is, try and understand that whenever your body is going to react, let us assume that your body is going to react at a number of 10. Let's assume that. Suppose this particular food item, let's say wheat or something, it is able to produce only number 3 or 4. It requires another additional 5 or 6 to reach to 10. Now, whenever you are taking isolated this particular food item, it is well below 10. So it is not producing symptoms. But suppose if another cofactor is coming, that could be exercise, that could be alcohol, that could be change in temperature, that could be drugs. So each of them might be contributing to 2 or 3 number. So ultimately, in different permutation combinations, your number touches 10 and then your reaction comes. So many times patient will say, the doctor, with this particular food item, I was getting reaction, and on another day I have not got reaction with this particular food item. So because it is not only the food, which is one of the factor or half trigger, it is actually the permutation combination of several cofactors, which ultimately you can say like make that particular golden number, which I am just assuming like 10 for an example, and ultimately the reaction happens. Please proceed, Dr. Puneet.
Sir, his clinical examination, first thing we saw was his airway, which was patent. His heart rate was 134 per minute. Respiratory rate was 32 per minute. Saturation was 91% with room air. BP was 80 bar 50. And temperature was 97.6 degrees Fahrenheit. And his peripheral pulses were feeble. And CRT was more than 3 seconds. So these were his vitals in our ER.
So what do you think that about these vitals? What is happening? Is it normal, abnormal? What is happening?
Sir, these vitals are normal, sir. There is tachycardia, tachypnea, hypoxia, hypotension with poor peripheral vascularization.
So absolutely. So we can say that this particular child or this particular patient is in shock. So because there is a hypotension which is there, so any adult with systolic blood pressure less than 90
90.
definitely classifies for hypotension. And then to compensate that, there is tachycardia. I was expecting with an adult somewhere a heart rate of around 80 or 90 will be normal. It is 130s. It is definitely high. Respiratory rate is high. Saturation 91% on room air is low. At least it should be 94. So definitely is absolutely correct that it seems to be shock. And as per the previous history, it was classified as anaphylaxis. So it will be anaphylactic shock, which was there. So I would like to ask you one question here. Uh, what will be the differences between anaphylactic shock versus vasovagal shock?
Sir, in vasovagal shock, heart rate will usually be low, but whereas in anaphylactic shock, heart rate will usually be high. In vasovagal shock, there will not be any known allergen that would be given prior to the attack. But whereas in anaphylaxis, there could be chances that known allergen like an NSAID or any drug or a bee sting or such allergy causing items could have been a predisposing factor. And there could have been other skin symptoms or GI symptoms or respiratory symptoms in anaphylaxis, whereas in vasovagal shock, it will just be the temporary unconsciousness with bradycardia, which we will be seeing in the patient.
Absolutely perfect. So yes, you rightly mentioned that bradycardia along with drop in the blood pressure, this is characteristic of vasovagal as compared to tachycardia along with drop in the blood pressure. But we need to take into the value that suppose even if the true shock, that means anaphylactic shock or septic shock or a hypovolemic shock, if it is picked up late, it is delayed, then at that time also the tachycardia might turn into bradycardia. So bradycardia might be in the later stage. It can happen even in a true shock also. But in a vasovagal shock, because it is the vagal overactivity, it is a cholinergic overactivity, and that is why it is the suppression. It is the suppression of the heart rate, suppression of the blood pressure, so both go down. And the second thing you rightly mentioned that about the triggers in the vasovagal shock, there will be no obvious trigger, but in anaphylactic shock there will be trigger and the temporal relationship which is also there. If you remember, you told earlier that for shock or anaphylactic shock or anaphylaxis, the person has been, you can say like the trigger is there, and then within 15 minutes to 2 hours, the person will is present with the symptoms, or maximum 4 hours, the person is present with the symptoms. But in vasovagal, even means like you can say somebody who has probably loaded the syringe and the patient started fainting. So there will be no time gap which will be there inside. So it will not follow the temporal relationship. Yes, please proceed further.
Usually, pain will be the trigger in vasovagal, sir.
Yes, anxiety, pain, phobias, all these things can happen. Yes, please.
So coming to the systemic examination, RS, he had tachypnea with bilateral occasional expiratory rhonchi, moreover the inferior axillary regions. CVS, there was tachycardia, S1, S2 present, no murmurs. Abdomen, it was non-distended with epigastric tenderness, but no organomegaly, and bowel sounds were normal. CNS, he was conscious and oriented, but also anxious with no focal neurological deficits.
Right. So here also, if you just say that you mentioned about tachypnea along with expiratory rhonchi, so that means this particular person is having some sort of airway spasm or bronchial spasm, which is happening, which is probably a part of anaphylaxis. Tachycardia, you have already mentioned. Per abdomen is fine, and then the central nervous system is fine to this particular patient. Yes, please proceed.
Local examination, He had generalized urticarial rashes present all over the body, more over the neck and trunk, associated with itching. He had flushing over the face and neck area compared to other body parts. Redness and itching of bilateral sclera was evident.
Like in this particular patient, there were some urticarial rashes which were already there. So that means there were some skin manifestation along with respiratory and cardiovascular compromise. So this was a clear-cut case of anaphylaxis.
Yes,
But is it possible that in a case of anaphylaxis, the skin might be normal or there are no urticarial rashes? Is it possible?
yes, sir. In 20% of the cases, skin could be normal, sir.
Yes. So we need to remember that the urticaria might be absent, skin might be normal in 10 to 20% of the cases, and still the person can be in anaphylaxis or anaphylactic shock. It is possible. Yes, please.
So our management in ER, we immediately started him off with 2 doses of 0.5 cc IM adrenaline given at about 5 to 10 minutes apart. After that, we put him on oxygen via mask at about 6 to 7 liters. 1 dose of salbutamol nebulization was given along with oxygen, and it was about 4 ml per nebulization. IV fluid NS bolus 2 pints, that is 1 liter, was given over 30 minutes. A tablet bilastine 40 mg was given orally. Injection ranitidine 2 cc IV was given. Foot and elevation. A continuous vitals and cardiac monitoring, that is ECG leads were connected along with the saturation probe, and he was later shifted to ward only after initial stabilization in ER. He was there for about 4 to 6 hours in ER, and then he was shifted to ward for further observation and monitoring once he had come back from the anaphylactic shock.
Right. So here there are in the management there are many questions. So first question is yes, it's a perfect management. There is no doubt about that. My question to you is that this particular person has come to you with you can say like in shock, and he was definitely not having any intravenous cannula in C2, and you proceeded with intramuscular adrenaline injection, which is absolutely the right step. There is no problem with that. My question is that suppose if this particular person has got IV cannula in C2 or intravenous line in C2 for some reason and went into anaphylaxis or anaphylactic shock, then by which route you would like to give adrenaline?
First 2 to 3 times would always be IM adrenaline, I would prefer, sir.
Very nice. So irrespective whether intravenous route is available or not available, you will go with the intramuscular adrenaline only, right? So why not intravenous?
Sir, intravenous, there could be lot of complications, most important being arrhythmias.
Yes,
So
arrhythmia.
that
Arrhythmia
is
is
the
the
most
first thing.
devastating complication which you would be expecting by giving it in intravascular route, sir.
Correct, correct. Now, other thing is that suppose if this intramuscular adrenaline means like in which particular muscle you would like to prefer to give intramuscular adrenaline and why?
Uh, Sir, anterolateral aspect of thigh, that is vastus lateralis muscle. Usually, the muscle mass is good there, and the pain tolerability is better, and subcutaneous fat is comparatively less there, sir, and more chances that we will be pricking the muscle if we give at that site.
Right. Suppose because of some reason this particular area is not available. Some patient who is having some scar there, some burn there, or some reason that this particular area is not available because of some reason. Is there any other area intramuscularly which you can probably choose in a
Sir,
given situation?
alternate thigh is the next option. If that is also not there, then deltoid I would prefer, sir.
Correct, right, absolutely, absolutely correct. Suppose if instead of intramuscular intravenous, what are the other routes of adrenaline which are possible, and whether you would like to opt them or not opt them?
Sir, first definitely is IM route. Next option, earlier they used to use subcutaneous route, but the absorption through subcutaneous route is variable. It could be between 20 to 36 minutes. But IM adrenaline, within 8 minutes, the absorption will happen, and we can see very good response, sir, because adrenaline is a pharmacological antagonist to anaphylaxis. So my first choice would always be IM adrenaline. Only if venous line could not be, IM could not be given, or venous line is not secured, then probably subcutaneous route. Only the two if the patient is not very, very sick. We
So
still have
subcutaneous
time to
route.
manage him.
So subcutaneous route in this particular patient is definitely no, because this particular patient is already in shock, and in shock your splanchnic circulation, your circulation to the skin is very much reduced, very much compromised. You yourself told that the pulses are feeble, the peripheries are cold, so there is practically no circulation which is going on inside the skin. So the subcutaneous absorption will be very low in this particular person.
36 minutes is what I read, sir.
Yes, yes. Now, what about the intratracheal route?
Sir, intratracheal route, actually, we have been, I have personally tried it, but not in the anaphylaxis patients. That has worked, but definitely not as better as IM adrenaline, sir.
Yes, so intratracheal route sometimes it can be thought of sometimes, but it is used mainly in the neonatal resuscitation. But the absorption, we really don't know that which particular dose, how much dose will get absorbed and how much it will not be. So it is not that real. And are you aware about any newer route which is nowadays available at least
Uh,
outside India, but not available in India for now?
Sir, FE, sir, nasal adrenaline shot.
Nifi, yes, very good.
Yeah.
Nifi. So Nifi is available, which is nasal one. Nasal is something like which we used to give like midazolam earlier in an injectable form, and now midazolam is available as a nasal spray. So same way, Nifi is now there as a nasal spray, and it there are studies which have compared it against placebo as well as against the intramuscular, that means EpiPen, which is standardized available there, and they have found equivalent results with good safety data. But it is yet to be coming to India. It is not there in India right now. Now, you mentioned about oxygen via mask and then fluids, definitely. So, my another question is that suppose you have already given 2 doses of IM adrenaline, and luckily this patient improved and he was stabilized and he was shifted to, you can say like ward, and then okay. But suppose if this particular patient is not improved after 2 doses of IM adrenaline, then what should be your next step in this particular person?
Sir, I would wait and give third dose of adrenaline, sir, in the next 5 to 10 minutes. Even if that is not working, then I would call up my ICU team to assist me. Then once my ICU team arrives, by the time they put IV line, I would keep repeating IM adrenaline every 5 to 10 minutes, sir. But
Yeah.
once IV line is secured, I would ask them to give adrenaline infusion one from zero point 0.1 micrograms to zero point 0.5 micrograms per kg per minute, sir.
Right. Any other alternative drug which you would think of in this
Sir,
particular?
we have also tried noradrenaline in those patients where adrenaline is not working. Suppose if they are cardiac patients or on beta blockers or sometimes ACE inhibitors, we should be keeping the glucagon also handy, sir. When
Perfect, perfect, perfect. So you rightly mentioned. So it is like something like a emergency. And in this emergency, whenever a patient comes to the emergency, then that means that is the 0 minute which is starting. And within 5 minutes, it's not at 5 minutes, within 5 minutes, as soon as possible, you have to give the first dose of adrenaline. Once you give the first dose of adrenaline, immediately order the second dose of adrenaline to be prepared by the nurse. So, because you don't know whether this particular person will respond to the first dose or he will require the second dose. So, you will always keep a second dose ready, whether it is needed, whether it is not needed, right? So, the first dose you have given, ask your nurse that immediately order for the second dose. She will prepare it for the second dose. You also monitor for the vitals, and simultaneously you examine the patient also. Sometimes a particular patient, for an example, a particular patient who is having, let's say, a obstructive shock. Obstructive shock in the sense the person is having tension pneumothorax, and because of the tension pneumothorax, the person is in shock. And we are here giving some fluid, we are here giving some adrenaline. The person will not improve unless and until you remove that particular tension, that particular needle thoracotomy, which is needed at that particular time. So you have given 1 dose of adrenaline, ordered the nurse that okay, please prepare for the second dose. Meanwhile, the next 3-4 minutes in which the adrenaline is going inside, you are monitoring the vitals, you are examining the patient continuously, that what else you can do for this particular person. You, if the patient does not improve, then you give the second dose approximately 5 minutes after the first dose, approximately. As soon as you give the second dose, now you don't know whether this particular person will respond to the second dose or not. Then immediately you will ask your nurse, okay, I am giving second dose. Please prepare the third dose of adrenaline. Please prepare glucagon. Please prepare adrenaline infusion also. And simultaneously, you call your ICU colleague. Then tell them that look, here is the gentleman who is this, and who is presented to us. I have already given second dose of adrenaline. Please come down because it is possible that he might require further assistance and require the intensive care treatment. So by the time the third dose you are giving, you must be having an ICU backup with you. You must be having your adrenaline infusion because immediately after the third dose, you have to give the adrenaline infusion continuously. You must be having glucagon with you. your oxygen gadgets and everything else with you. So it is something like a time critical emergency, and which must be running like a clock, which is important. And that is why the message is that I would like to request every one of the listeners that please try and practice this even on your simulations. In simulation labs, this is important. You please connect with your ICU colleagues and ask them that how quickly and how swiftly it needed to be done. It's not that okay, adrenaline is the drug of choice and then thereafter the subject stops there, because this is something which is like a life threatening emergency. Anything can happen at that particular time, and we need to act very fast here. So yes, Dr. Paneet, please proceed further.
Yes, sir. So once we settled him in ER, he was shifted to ward, sir. He was discharged 2 days later.
Yeah.
So investigations we sent him were CBC, which was normal, ESR was 19, thyroid profile was normal, serum tryptase, which was sent within 1.5 hours of the onset of the first thing was rashes. From the time of onset of rashes, within 1.5 hours, he has reached our hospital and we have sent tryptase. Its value was 10.1 nanogram per ml. And after 2 days before, just before his discharge, we did a repeat serum tryptase. It was 4.05 nanograms per ml. And SPT was done 6 weeks later, where saline was 2 into 2 and histamine was 9 into 8. So this test could be read now. We saw sensitivity to cockroach 10 into 6 and prawn 6 into 4. We went back, asked the second history, but no way the second history was correlating to what he had, the episode what he had all the 3 times. He had never had prawns all the 3 times in all the three anaphylaxis he had till now.
So few questions, Dr. Puneet. First, what is the significance of tryptase here with an acute value of 10 and a baseline value of 4?
Sir, serum tryptase is an indicate is like a biomarker for anaphylaxis. If it is definitely the difference between the acute value and baseline value is significantly high, then we can actually confirm anaphylaxis. But that does not mean if the value is normal, it is not anaphylaxis, because anaphylaxis is a clinical it's a clinical definition. We need not require any lab tests like serum tryptase. It's just for confirmation. Now, in our case, acute value is 10.1 and baseline value is 4.05. Though the normal value of serum tryptase is less than 11.4 nanogram per ml in most of the labs, here none of our values are reaching more than 11.5. Still, it can be considered positive because there is significant increase in the acute value compared to the baseline value. So, if the baseline value is 4, so 4 into 20% of 4 plus 2 is definitely more than 10. So that is why we can consider this tryptase value as significantly positive.
Right. As you rightly mentioned that in a suspected case of anaphylaxis, anaphylaxis is a clinical diagnosis. And if you are already there on the bedside and you have diagnosed that this is anaphylaxis, then at that time you need not to have tryptase to manage this particular patient at that particular time. But sometimes if a particular person who is, you can say, like probably faking the anaphylaxis type of episode, like for an example, there are certain psychogenic patients who are faking the symptoms because of certain reason, and each and every time they are presenting to one or other emergency every 15 days, every 20 days, and the things are not fitting somewhere, then at that particular time it is always better to, you can say, like send a pair tryptase and see whether this particular tryptase is correlating with their symptoms or not. So this is one. The other thing is that even the baseline tryptase value, sometimes it is high, sometimes it is, you can say, like 15, 20, 25, 30, or even in hundreds also. So that means that the baseline reactivity of the mast cells, this is high. So this particular patient is already on, you can say, like a higher risk of recurrent anaphylaxis, which is important. So tryptase is usually done just to see whether, you can say, like to see the baseline status, and simultaneously in a patient in which you are not actually thinking about anaphylaxis, but you just want to prove it at that particular time. Now, coming to your question about the skin prick test, I understand that here the sensitization is positive for the cockroach and the prawn. My question to you, whether wheat was checked here or not,
Wheat was checked, sir. Whole wheat extract was checked.
and it was negative,
Negative, sir.
which is very important. And the other important thing is that here the prawn was positive. So suppose if this particular person who is taking prawns or who is taking seafood, so seafood is another important I will say, reason for food dependent exercise induced anaphylaxis. So this would have become important here. But when you are telling me that the history is not correlating and person has never taken it, so it could be possible that the person might be sensitized to, let's say, cockroach, and in that cockroach tropomycin. And because of the tropomycin, even the prawn test is coming positive, but actually it's not a true positive. It is a false positive, or the cross activity, it is showing positivity. Yes, please go ahead.
Sir, so we went ahead and sent a CRD the same day when we did a skin prick test. It was inconclusive. CRD will also give total IgE, which whose value was more than 2,500 kilounits per liter. Also, amongst all the allergens which the CRD tested, we could see that a TRIA19, that is omega 5 gliadin, showed a significant, that is high risk value of 6.89, which has come positive. Also, spelt, which is a form of wheat which is used in Europe, that also has shown a high value of 3.07. Here, if you come down, there is one more, a tri-AAAT1, that is alpha amylase trypsin inhibitor, which is negative, and tri-A14, which is NSLTP, is also negative. So CRD is telling that he is positive, or he is sensitized to omega 5 gliadin and also to spelt.
Yes. So here I would like to means like mention few things. First of all, with this report is from LX2 technique. So this LX2 technique, the total serum IgE is not reliable. Many times we have seen that when we are ordering a total serum IgE from the your standard this immunocap type of technique or ELISA type of technique, so there you get the absolute values. But here, with the total IgE, values are not matching or not synonymous with those isolated values. So I would not like to keep this total IgE value any value. One. Second thing is that any value, like here it is written more than 2500. What it means? More than 2500 could be 2501 or it could be 25,000. I really don't know whether it is 2501 or 25,000, right? So this particular total IG, I would not like to give any value to it. Yes, I agree with you that omega 5 gliadin, yes, the titers are present and they are positive 6.89. And the other components of wheat, which may be responsible for wheat dependent exercise induced anaphylaxis, one is NSLTP, that is tri A14. But here it is negative. So, yes, omega 5 gliadin is definitely positive here. And the history is also suggestive. If you just go back to the history in which the person has told that he has taken breakfast and then thereafter he has done some exercise. So, I think this is matching with your history. So please proceed.
And that day, when he had breakfast, like he reached Bangalore, he had breakfast. Third episode of Anaphylaxis. He reached Bangalore from Ballari, like which is about 350 kilometers from Bangalore. He had a puri as his breakfast, sir.
Yes, yes.
So puri again contained wheat. This I got
Correct.
to know through second history.
Correct.
So coming to the discussion of wheat-dependent exercise-induced anaphylaxis. So it is a severe Ig-mediated allergy occurring when wheat ingestion is combined with cofactors like exercise, most importantly, or sometimes alcohol or NSAIDs. It was first described in 1970s. It usually occurs when wheat is ingested 1 to 4 hours prior to or after exercise. Weight dependent exercise induced anaphylaxis is the most common cause of food dependent exercise induced anaphylaxis, which accounts to about 30 to 35% and is often triggered by omega 5 gliadin, which is a major allergen. So exact prevalence of wheat dependent exercise anaphylaxis in India is definitely not known, but overall with most of the studies which were done, it was shown that 0.06% in primary school age and 0.017 to 0.2% in high school age was the prevalence. In India, definitely most of the times it goes unrecognized or underdiagnosed or misdiagnosed as idiopathic anaphylaxis. Coming to the age and gender, it can affect any age, but most commonly amongst teenager and young adults. Male is to female is as 1:1 ratio, and few studies have shown that there is slightly high incidence in males. So, discussing about the cofactors other than exercise, the cofactors mainly are first most important thing is NSAIDs, which significantly increases the absorption of those proteins which are responsible for the anaphylaxis, mainly aspirin and ibuprofen, which have been implicated, alcohol, which increases GI permeability, stress, which primes the immune system, same with the infection, menstrual cycles, which exacerbates the sensitivity to have a reaction, same with travel and exhaustion, which we had in this third episode of anaphylaxis. Temperature changes, it is extremes of temperature, too hot or too cold can also trigger an anaphylactic reaction acting as a cofactor, or like sorry already told, combination of above cofactors are actually more important than a single cofactor. Pathophysiology. Exercise causes increased GI permeability, which is also called as leaky gut, causing massive increase in omega-5 gliadin levels in the blood, for which IgE antibodies bind and cause reaction due to mast cell degranulation. The second probable theory is increased tissue glutaminase activity in the gut. The other proposed mechanism is exercise induced blood flow redistribution. However, none of these are proven. However, the first pathophysiology is widely accepted. So this is a pictorial representation where we see a person is running, like doing exercise after eating bread. Due to this, there is a leak in his gut here. There is leak in his gut. So we can see this leaky gut and all these wheat proteins are entering his bloodstream. And once this omega-5 gliadins are entering his bloodstream, this is binding to the mast cells, IgE or the mast cells. So already sensitized IgE is now causing mast cell degranulation. With this mast cell degranulation, there is the release of most of this inflammatory mediators, mainly histamine, which causes the systemic symptoms, mainly hives and rash, angioedema, breathing difficulty, and other signs of anaphylaxis we already discussed.
Absolutely, absolutely. And if you just see this figure, so the other factors which you more mentioned is about like during exercise, what happened that it is something like a uh, fight and flight response which happens. What means that during that particular exercise time, majority of the blood circulation which goes into the peripheral musculature, so it goes to the skeleton muscles. So what happens is that the gut absorption, so gut permeability increases, and the the in partially digested, so the partially digested peptide molecules or the protein molecules, they get absorbed. So the partially digested protein molecules are more allergenic because they are not completely digested. So these more allergenic proteins like omega-5 gliadin, they get absorbed in a more bigger content, more higher content. And then because of the redistribution of blood flow towards the skeletal muscle, so they move faster towards the skeletal muscle. And in the skeletal muscle, the mast cells, they are having lower threshold of degranulation. So in a way that they get, these mast cells get the fuel, and the fuel is added to the fire because they are already at a lower threshold to degranulation. So that is why the reactions happen much more faster at that particular time. And here lies even one preventive step also, that majority of the time gyms open in the afternoon, in the evening, or in the night, which is wrong, physiologically wrong. Ideally the exercise must be done in the early morning hours, empty stomach. So the right time to do the exercise for any sort of physical exercise is early morning hours, empty stomach. So the person wakes up in the morning, early in the morning, somewhere around 4 o'clock or 5 o'clock in the morning, do some exercise, whatever they want to do, and thereafter, after a little rest, then they take their breakfast. So then they will be okay. But because of our lifestyle changes and everything, we have actually changed, you can say, like reverse the cycles. So the food is on the move, the people are now moving, but they do not have any time to eat, and you can say like sit and eat. So they are just eating and moving, eating and moving. So that actually adds up. So these all things are, you can say, like we are paying the price of these bad lifestyles. So which needs to be corrected as early as possible. And especially I just told you about the timing of the gym we're opening, which is physiologically absolutely incorrect time which is they are opening. Please proceed.
Types of WDEIA, that is, the subtypes are depending upon the type of allergens. So there are two types mainly. the one due to gluten allergens and the other one due to non-gluten allergens. So coming to the gluten allergens, omega-5 gliadin is the most important or the major allergen present in gluten fraction of wheat. That's why wheat-dependent exercise-induced anaphylaxis is also known as omega-5 gliadin allergy sometimes. And its immunocap sensitivity is 80% and specificity is 96%. Other wheat gluten allergens that can cause WDEIA are high molecular weight gluten subunits, that is HMWGS, low molecular weight gluten in subunits, that is LMWGS. Also, there are other gliadins like alpha, beta, and gamma gliadins. So these family of proteins can cause allergy through gluten allergen mechanism. The non-gluten allergens that can lead to WDEIA are, that is omega-5 gliadin negative WDEIA. It's also called omega-5 gliadin negative WDEIA. It is due to mainly tria-14, which is a wheat lipid transfer protein. Here, asymptomatic sensitization is frequent, more than omega-5 gliadin WDEIA. So, tri-A-WDEIA has stronger association with atopy, has high cross reactivity with other foods, mainly nuts and cereals. Whereas in the previous gluten, that is omega-5 gliadin WDIA, there need not be atopy history or there need not be any cross reactivity with other foods. This is the difference between the two. There are also other a few minor subtypes of WDEIA. Percutaneous sensitization to hydrolyzed wheat proteins used in soaps, shampoos, cosmetics, etc. has also been reportedly significantly increased in the previous few years, especially in Japan, where they saw WDIA in about 1,340 individuals, Japanese citizens, who used these soaps or shampoos containing HWP product. And when they got to know that this was the issue, this HWP containing cosmetics were banned in Japan. The other minor subtype is grass pollen allergy related WDEIA. This probably is due to cross reactivity between grass pollen and wheat, because basically wheat is also a grass. So these are the subtypes of wheat dependent exercise induced anaphylaxis. Clinical presentation of WDEIA. Symptoms typically appear during or immediately after exercise, mainly involving skin, respiratory, GI, and CVS. So in the skin, the patient can present with urticaria, flushing, angioedema, itching. In respiratory system, he can present with wheeze, shortness of breath, voice change mainly. In gastrointestinal system, nausea, cramping pain, vomiting, loose stools. In CVS, he can present with hypotension or with collapse. Usually, if you ask any a case of anaphylaxis, they will definitely tell they sensed impending doom. Diagnosis of WDEIA. First step is always a good medical history. Next thing is skin prick test with whole wheat extract and even wheat gluten if available. For HWP WDEIA, products containing HWP or pure HWPs itself could be tested, and prick on prick test can be done in full concentration. Specific IG is the next test that helps in diagnosis. If negative to whole wheat extract, if a specific IG is negative to whole wheat extract, again, specific IG to omega-5 gliadin and tri-19 should be asked for. In HWP WDIA, these values will again be negative because it won't be represented. So CRD is another important diagnostic tool where we are not having any confirmatory evidence of WDIA even after SPT or with specific IgE, which we did in our case. Oral challenge test. So coming to oral challenge test, even though this is gold standard, it needs the need for adding cofactors and lack of standardized protocols has hampered its utility. There are few centers in Europe which do this, but again, they don't have a standardized protocol and it is not widely accepted. Serum tryptase definitely to actually confirm the diagnosis of anaphylaxis if in doubt. both acute and baseline values can be sent.
So about the challenge test which you mentioned, so the challenge test is usually done like on different days. Like for an example, once you have suspected, okay, this particular food item is the culprit, then what you do is that on the first day you will just expose this particular person to this particular food item, and the challenge will be negative. That means the person will not react to this particular food. Second day, suppose if you are also expecting certain drug, like for an example, non-steroidal anti-inflammatory drug or any other particular drug. So you will just challenge that particular drug, the person will not react. Or on the third day, the person will be subjected to that quantum of exercise which you feel that, or the person feels that, okay, this particular exercise has triggered the reaction. So only that particular exercise the person will be subjected to, and the person will not react to it. But then the next day, probably the fourth day, now all things in sequence. That means the person has taken that particular NSAID if that was already earlier taken, or not taken, so that not needed, then that particular food item, and within, you can say, like 2 hours time period or 1 hour time period, then that particular exercise is done. And suppose if the reaction happens, so this is confirmatory, but this can only be positive in 70% of the cases. Rest 30% of the cases, even this test can also be negative. Reason behind, because as rightly mentioned, that probably the quantum of exercise which was needed to reach up till that threshold of 10 might not be achieved in the controlled condition. The type of food, the quantity of food which you have used might not be sufficient enough. Even the external things like external temperature, or even the stress in the person, or even there are certain other factors which are non-controlled, they might not be there, and ultimately you are not able to reach up to that value of 10. You might have reached only up till 8 or 9, and the person might not through the symptoms. So that is why in 30% of the cases this could also be negative. And definitely, if somebody is doing it, it is a high risk procedure and must be done in the equipped centers by the, you can say, like the qualified people only. Otherwise it is not recommended. But yes, it should be the test of choice, or the you can say, like the gold standard test.
Yes,
Please proceed.
yes, sir. So, management of weight-dependent exercise-induced anaphylaxis. So, physical exertion and weight consumption to be discontinued immediately while he is during that episode. Anaphylaxis management protocol to be followed, and written anaphylaxis action plan is to be given and explained and also demonstrated to the patient. Patient should be emphasized to carry EpiPen or manually prepared adrenaline injection, which we usually use in India, with them all the time, and indications should be clearly explained. Cofactor awareness, which is also very important, is to be given to the patients, mainly alcohol and NSAIDs. Buddy system. So this is always exercise with a partner who knows about your condition and who can do the first aid. So always the patient with WDEIA should do exercise with a partner only who knows about his condition. Reading and understanding food labels, both patient and family members should be involved in this. To tell waiter in hotel that they have food allergy when going out is also a good thing. To be aware of cross contamination of food allergens when food is being prepared. Wear a medical alert bracelet. So all these are part of management of weight dependent exercise induced anaphylaxis. But mainly individual dietary counseling, considering the patient's reaction threshold based on history, and challenge test if done is the best way to advise about his diet. All does not fit. I mean, the what advice we give does not need not be appropriate for all the patients with WDEIA. It should be customized. It should be individualized depending upon each patient. A diet totally free of wheat and cross-reactive cereals, that is, a gluten-containing cereals, wheat, barley, rye, oat, is to be chosen, especially for low reaction threshold individuals. But in most cases, situational avoidance should be discussed, allowing them to eat adjusted quantity of gluten-containing cereals, separated from a cofactor by at least 4 to 6 hours. This specific approach has been shown to increase tolerance in contrast to a reduction in reaction threshold for patients showing strict dietary adherence. So the third part here is supposed to be best, but the patient should have a bit higher threshold to follow this criteria. So this is coming back to our patient. This photo, this my patient sent this to me today. I just asked. He was in his office when I actually called him up and asked him to send a photo. He had these things in his bag. That means he's following my advice. We can see a Bilasure tablet here, which the dermatologist has prescribed because he had CSU since the last 20 years. And this is manually prepared adrenaline injection, which was given to him about 2.5 months ago, where we can see clearly mentioned that it is injection adrenaline. It has to be given IM dose. It is 0.5 ml. And we've also written the expiry date and also asked him to refill it once it is expired from a nearby hospital. Here we can also see that he is placing this adrenaline injections in a spectacle cover so that it does not expose to sunlight and does not get denatured. So coming to the future option, slit with wheat gluten to increase reaction threshold is being studied, but larger studies are needed in this regard. Because most of the European countries, their staple food is wheat, and there this allergy is more common and more diagnosed than compared to our countries. So, in conclusion, WDIA is a complex underdiagnosed condition. Omega 5 gliadin is the most common biomarker. Education on timing and cofactors is the primary cure.
So I think Dr. Puneet, well presented, excellent presentation.
Thank
Uh,
you.
yes. So few things. As we have discussed now, this wheat dependent exercise induced anaphylaxis or food dependent exercise induced anaphylaxis. Now you can stop your presentation actually, so we can have some discussion. Yes. So this wheat dependent exercise induced anaphylaxis or food dependent exercise induced anaphylaxis is also called as uh, AFIFA. What it means? It is called as augmentation factor induced food allergy. That means it is not only the exercise. There are several other augmentation factors which you mentioned, that these could be certain drugs like NSAIDs. These could be even other cofactors which are also there: extremes of temperature, menstrual cycle, stress, so which we discussed about all those things. So that's why the correct term is now called as augmentation factor induced food allergy. So which is there. So I'm just now going through certain questions which are there on the chat box. So is there a relationship with NSAID? What is the mechanism? I think you've already answered that yes, NSAID can also increase the permeability, and ultimately it actually erodes the gastric mucosa and it increases the permeability, and ultimately more allergenic proteins they are getting absorbed, so that's how it can cause problem. Another question is that can any gastric irritant can be a cause or a cofactor related to this incidence? We need to really understand the mechanism is that the the partially digested protein molecules or more allergenic protein molecules, when they are getting absorbed, then at that time there are higher chances. So any factor which is leading to that might be a cofactor, could be a weak cofactor, could be a strong cofactor. Now, the other question is, what is the epidemiology in India? Should all emergency medicine physicians be sensitized on this? So, this is a very good question. And even at my center also, uh, I have just submitted a case series of food dependent exercise induced anaphylaxis of 20 patients. And this case series was over only 9-10 months of duration only. So, that means the patients are around us. It is only the index of suspicion or high index of suspicion. If we hear to the patient, listen to the patient very carefully, what they are telling, what they are speaking about, work up them rationally, and then follow them up, then definitely this particular entity is not that rare, and we can definitely have more numbers of the patient which are around us. And definitely all the emergency medicine physicians must be sensitized to this. I am not saying all the emergency medicine physicians, I am saying everyone. Where there is a food, where there is an exercise, these things can happen. That means all the eateries, they should be sensitized. All the places like gyms, they need to be sensitized that these things can actually happen and why these things happen. So they need to be prepared with these emergencies. That is very important. Then, which is the most common food causing it in India? So, by literature says that it is wheat and seafoods. But like I am working in North India, so where the wheat is much more culprit, but around the coastal areas, seafoods are also much more culprit. But these are not the only two foods. There are other food items also which can also cause, and practically they say that any particular food item could be the culprit. You mentioned in your presentation even nuts can also create problem. So this is also possible. Other cereals can also create problem. Then Belastin dose 20 milligram, 40 milligram. I think 40 milligram maximum the people are using. So regarding the case series, so case series is going to be published soon, and as soon as it will be published, then I will be sharing with you all. So, but thank you for an excellent case presentation and discussion and the excellent questions by all the viewers. So thank you very much, Dr. Puneet.
Thank you, sir.
With this, I would like to now conclude today's session with all the things, and we will see you once again with another session on second week, second Tuesday, and fourth Tuesday. So, second Tuesday will be our Global Frontier lecture series. So, the next session will be on 10th March, and the fourth Tuesday will be our Clinical Excellence Masterclass, like the case presentations which Dr. Puneet did today. So, we'll see you on the second Tuesday of March now, that is 10th March 2026. So, good night, everyone. Thank you. Thank you once again.
Thank you, sir.
Thank you.